Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And in this podcast, you'll hear from a diverse representation from our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. Well, it's great to be here again today with my co-hosts, Dr. Arjun Ghosh and Dr. Dan Lenihan. Dr. Ghosh from London, Dr. Lenihan just south of St. Louis in Cape Girardeau. And as listeners will know, we frequently have cardiologists represented from different aspects of the cardiology world. And we're thrilled today to welcome some of Arjun's colleagues who work on the other side of the discipline in the oncology hematology world. So Arjun, why don't you go ahead and introduce your colleagues today?
Great. Thanks so much, Steve. So really looking forward to this episode because we will get the perspectives of not only a medical oncologist, but also a hematologist who deals with cancer patients. So really covering the full spectrum of cardio-oncology from the oncology side. So we've got Dr. Andrew Wilson, who's a consultant hematologist at University College London Hospital. And we also have Dr. Rebecca Roylance, who's a consultant medical oncologist at University College London Hospital. So really looking forward to this episode.
Thank you, Arjun. Before we jump in with particular questions about your work, I wonder if each of you, Rebecca, maybe start with you, if you could tell us just a little bit about kind of your career path, your background, and how you developed your interest in cardio-oncology in particular.
Sure, thank you. Well, I'm a consultant medical oncologist, as Arjun says, specialising in breast cancer. And so I think my interest in cardio-oncology has, of course, risen from the fact that a number of our drugs cause cardiotoxicity. But of course, our drugs are increasingly successful with women living longer, with both being cured of their cancer and living much longer with their metastatic disease. And so we, of course, need to try and limit their morbidity from our drugs. And where necessary, we're obviously really keen to keep our treatments going. And so that's where I need help from my cardio-oncology friends in order to both minimize that toxicity and keep their treatment going.
Great. Thank you so much for that background. And Andrew, tell us a little bit about your background and how you developed your interest in cardio-oncology.
So I think my my interest in cardiology probably goes back to before I was even a medical student. I actually did a PhD and a postdoc in the molecular biology of long QT syndrome. So I still feel like I've got some skin in the cardio-oncology game, even though I'm a hematologist now. And I look after people with chronic and acute myeloid neoplasms, so ranging from the chronic myeloproliferative neoplasms like ET, PV, and myelofibrosis, all the way through to acute myeloid leukemia. And I'm frequently ringing Arjun and colleagues when we have some very difficult case, as often happens with short notice in acute leukemia. Where we need to crack on and get treatment, and there's some cardiology problem that we need to resolve.
Thank you very much. That's very helpful as well. Dan, welcome today. I wonder what questions you might have for our guests.
Yes, thank you. Thank you all so much for joining us today. And it's always a great pleasure to really hear, a perspective of the hematology and oncology physicians, and how we make our decisions. But I would say that, especially on the hematology side, the whole question of how you anticoagulate somebody with some sort of cardiovascular complication is easily the most challenging question. And so depending on the leukemia or the hematology condition that's being treated, there are a lot of subtleties. So I was just curious from both of your perspectives, but maybe I'll start with Andrew, that how do you assess your patients from a cardiovascular perspective? I mean, is that something you take into consideration when you're making your choice about what you're going to do?
I mean, undoubtedly that forms part of our assessment. I guess it varies depending on whether we've got time to think about things and work people up more comprehensively versus whether it's an urgent decision where we need to start chemotherapy, but it's thinking about the disease that we need to treat, the biology and the kinetics of that, the likely treatment that is available or licensed in the UK that we can reach for, and what some of those side effects are, and absolutely the clinical status of the patient from a global health perspective, not just their cardiovascular status, but their physiological reserve, their performance status, and increasingly, particularly in AML, frailty assessments, because AML is primarily a disease of the older adult. So do we do that formally using risk assessment scores? I think not so much, but we probably need to do better at that.
Yeah, and Rebecca, I think there was a paper a couple of years ago. Dr. Hortabaji from MD Anderson had like 45 years of breast cancer treatment. It was this really beautiful review. I think it was in Journal of Clinical Oncology. And he had this nice figure, and you could just see as he goes from the left of the page to the right side of the page, you started out with like one choice. And then by the time you got to 2010 or 2020, there's like 50 choices of which medicine you're going to use and how you're going to use it and how long, et cetera. And I'm sure that's your everyday life. But how does cardiovascular disease factor into those decisions?
Yeah, I mean, you're right. We have loads of treatments. And of course, that's what I always think makes breast cancer, the most interesting cancer to treat, because we've got so many options. So I guess for me, there's sort of two big categories, really. It's the anthracyclines that we obviously have to really focus on any risk factors, because you don't want to be causing permanent heart damage. Andrew talks about the older patients, the frail patients. Of course, we have a proportion of those as well, but we also have young women, young women who might not yet have had their families. And so we really need to be minimizing any toxicity. So I guess are they fit for an anthracycline is my kind of, thought processes. And of course, if they're not, then we are increasingly lucky with breast cancer. We can avoid the anthracyclines. It's not like, for example, sarcoma, where anthracyclines are the real bedrock of treatment. So we do have options, and the field is really moving away from trying to avoid anthracyclines. But, the HER2 positive population, of which that accounts for about, 20-25% of our patients, those are the ones where we really need to be doing their cardiac assessments. And of course, we use echoes. Our cardio-oncology colleagues have taught us all about GLS, which was a real thing that I hadn't heard of or understood before. And so knowing that, it's not just the LV function and the number, but it's looking at the GLS and changes in that with time as we monitor women on treatment. So I would also agree with Andrew that I think that whole formal risk assessment that's sort of came out as well in the recent guidelines is something that we've got to get to grips with as to how do we do it more formally, but certainly from the patient's history using echoes, that's the sort of assessments we do routinely currently.
Yeah, I think you sort of referenced the guidelines that came from the ESC, yes, European Society of Cardiology, and in combination with ICOS. But I would say that it's an awesome document. It has a tremendous amount of detail and all that. But as a hematologist or an oncologist, I can't really see that you're even going to refer to it, honestly. I mean,
Well, glad you said that.
Yeah. I mean, I don't see how that's possible because, like, if you say, well, okay, Dan, did you look at the latest update on, chemotherapy for ASCO? And I would say, you've got to be kidding me. I mean, no way. I can't even get through the cardio-oncology guidelines. How am I going to get through those? So, yeah, I mean, I think it's a great document, really amazing. But on the other hand, you don't want something to exist kind of in its own little world. You want something like that to be useful. Yeah. So I guess my question to you guys, how can we make that useful? How could it be helpful in the day-to-day management decisions that you have to make?
So, or shall I go first, Andrew? I guess I'd say it needs to be a bit more bite-sized. You're right, it's absolutely enormous. And I think it also has real resource implications. Quite frankly, at the present, we don't do an echo for every patient with, who's about to start anthracyclines. If they're fit, they're young, they've got no other comorbidities. We're limiting the doses. So I think certainly in the UK, we wouldn't be able to manage, I think, if with the intensity of the increase in numbers of echoes that we would need to do. So I think it's that we've got very good algorithms. We know how to monitor Herceptin with our echoes, the frequency, what to look out for. Targeted therapies like ribociclib, we know what we need to do in terms of ECGs, monitoring the QTC. So I think it's having a framework that's much simpler to follow would be my thoughts about how to make it useful.
Yeah, so you brought up the concept of ribociclib. And if you thought about, now I don't know if you've seen 100 patients where you've started ribociclib, but let's just say if you had, and you made a tally of the last 100 patients that you started ribociclib, try to be honest on this one. How many EKGs at baseline did you do? And did you do an EKG at 2 weeks and 4 weeks?
Yeah.
What would be your estimate of the percentage of patients that had each of those 3 EKGs?
Yeah. So we're pretty good at doing that. I think perhaps the bigger challenge is reading the ECGs and working out whether the QTC is prolonged or not. And the ECG machine tells you. We had a lady the other day that the ECG machine told us it was a prolonged QTC, which kind of put us in a bit of a spin and had Arjun on speed dial. But then when you calculate it, it was actually within limits. So. So at the moment, we are being very good and we're doing it regularly like that. Certainly during COVID, that was a real challenge. How do you do ECGs in that sort of situation when you're trying to keep patients out of the hospital? And so it was a much greater challenge then. And of course, we're in the lucky position of having different CDK4/6 inhibitors to use. So perhaps, certainly if you're worried about the heart, you just use a simpler one.
Yeah, and I think the whole issue of whatever the recommendation is, how strong is it, number one, and number two, how imperative is it to make a decision about what your treatment is? And
yes, so, indeed.
In Andrew, in your case, you're going to be thinking about whatever the best leukemia therapy is, that from your point of view. And I mean, how much is your cardiovascular assessment going to bear on that?
Well, it's highly variable. Obviously, with things like AML, so very aggressive tumors that grow very quickly, you may only have one chance to get into a remission. So we really don't want to compromise the delivery of the systemic anti-cancer therapy. Obviously, if we try and echo everyone. We have a very responsive inpatient echo service, so we can get, usually same day echoes for patients with leukemia, so we can make a decision in terms of their cardiovascular status before giving the first doses of chemotherapy. And clearly somebody who's got a very compromised heart, it will influence what we decide to give, or whether we give one dose of the cycle of treatment and monitor very closely before giving the subsequent doses. So I think it is quite variable, but it is clearly very important. And that's, from a more routine perspective, the ones that cause us all a bit of stress and have Arjun on speed dial are the people in DIC who have got no platelets and are having an ST elevation MI, concurrently, and people who have, acute coronary syndrome with no platelets, and how you pursue that is the icing on the cake for the cardio-oncology team, because they are far more challenging, and things where there's really, despite the extensive guidelines that have been produced, that there's not often a right way forward for how to manage them.
Yeah, you'll also notice that if you do happen to grind through the 133 pages of those guidelines, you won't find any guidance for the cases that you're talking about.
Correct.
The bigger question is does Arjun answer his speed dial?
Most of the time, we're quite persistent, but either Arjun or one of his esteemed colleagues is generally available. And we count ourselves extremely lucky to have such a responsive cardio-oncology team at UCH. And of course, one of the issues about the guidelines and how they might play out elsewhere around the country is that we are quite lucky with the resource we have available, and there are many other places outside London around the country that could not hope to implement a fraction of those guidelines due to resource limitations.
The Global Cardio-Oncology Summit is the leading yearly update in cardio-oncology. This year's meeting will be held in Madrid, Spain, gathering the top experts in research, science, and clinical care from around the world. The 4-day event begins on September 27th with a basic and translational research symposium. On September 28th and 29th, the main sessions will take place, and this fantastic event concludes with a half-day session focused on cardio-oncology nursing on September 30th. New this year is the ICOS Champions League competition, a friendly and fun quiz event centered around cardio-oncology knowledge and clinical cases. The Champions League competition is open to all healthcare professionals, so make plans to join in. For more information, visit icos.org, that's ic-os.org. We look forward to seeing you in Madrid this September. Treat cancer, protect hearts.
Yeah, so Arjun, I don't know if you want to speak for yourself there, but these are the real issues. Those are the situations where you have to make a variety of decisions, and there's really nothing that's going to tell you how to do it or what to do, and so you have to just go with available resources.
Yeah, and I think probably in those challenging questions or the challenging cases that Andrew mentioned, there's a strong role of the cardio-oncology MDT, and that's something where we really like to bring together imaging cardiologists, heart failure cardiologists, interventional cardiologists, EP cardiologists, along with the oncology team. And I think in all of these, similar cases, even for the inpatients, we discuss them, at our weekly MDT. And I personally feel that given the minimal evidence in some of these areas, it's very much a learning and education experience for us on an MDT to MDT basis. I mean, Andrew and Rebecca have both been involved in the cardio-oncology MDT, so maybe I could turn it over to them as to what they feel about the MDT and the strengths and weaknesses. Maybe Rebecca, if I could start with you.
Yeah, sure. I mean, I think the strength is that you've got all the relevant expertise in the room, which, as Andrew says, we're very lucky to have. But, we can really focus on the risk-benefit ratio to that individual patient in terms of their cancer treatment versus the competing morbidity of any cardiological problems. And often in medicine, things aren't black and white and straightforward. And so it's those, as you say, it's those complex cases which really benefit from some time where we can discuss how best to manage them from the different specialities.
I mean, I would absolutely agree with that. We're often dealing in an evidence-free zone where there is no guidelines, there's no evidence, and having an MDT of experts, who can all contribute their expert opinion to achieve the best outcome for the patient is a real benefit and a bonus, I feel, for us working here at UCH.
And I guess one of the other issues that Dan maybe touched upon was the resource implications, and maybe, how do we help others in less resource intense environments? And I think that, education is one of those, cornerstones. And I know that Andrew and Rebecca, you're both involved in educational activities in the cardio-oncology space. I don't know if Rebecca, you wanted to elaborate on that.
Well, we have an annual course where we get oncologists, cardiologists together, and we think about the sort of challenges that we face from our perspective in oncology. So, we've touched upon some of them already, those falls in LV, what do we do? Prolongation of the QTC and the complicated cases that Andrew talks about that I'd have no idea how to manage from either angle. So it's there's common themes that we're all struggling with, and as the new drugs come through with ever more sort of potential cardiac toxicities, it's a case really of learning from each other. As oncologists, we're increasingly being expected to understand how to manage diabetes because our drugs give us, hyperglycemia and so on. But there's nothing quite like being able to liaise with the experts who know about the particular medical problem, so that we can, have that education and optimize the patient's management.
I certainly think from an education point of view, which is one of my major interests, it's really, I give a talk every year to our new hematology registrars about, systemic anti-cancer therapy. And every year it's a longer and longer list of new drugs with new mechanisms, with new side effects. And, you just think that actually that's quite difficult to keep on top of it. And what we need to do is kind of teach people an awareness of the issues of the cardio-oncology, and provide a schema by which they can troubleshoot and problem solve themselves. I think we're not going to upskill the entire medical population in the UK to have this kind of lexicon of terms that we use, but we are going to need to highlight the problems that can occur and signpost people to where to find an answer. And that's part of the remit of the course, which is case-based primarily rather than kind of lecture-based, where we focus on the clinical dilemmas that we face in routine practice and try and solve them for the participants. And I think that kind of type of course, I think, has been very successful so far, and will hopefully continue with our next iteration this November, Arjun and Rebecca.
Yeah.
Indeed. So it's nice to hear what your thoughts are from the oncology and hematology point of view in terms of education. And I suppose one of the last questions I have is a lot of cardiologists for sure do ask me about how they can set up a cardio-oncology service in their own hospital often, a smaller hospital, a district general hospital. So I guess my question first to you, Rebecca, would be if a breast oncologist or a GI oncologist, came to you and said, we're seeing a lot of these cardiotoxicities, how can we set up something locally from a cardio-oncology viewpoint? And then, Andrew, from the Hem-Onc point of view, if somebody came to you. So Rebecca first, how would you answer that question?
So I think, if you're working in a centre without cardio-oncology support, you'd be really keen to try and set it up. I think that a breast clinic is the kind of almost the natural starting point because of, as we've already talked about, the anthracyclines, the HER2 targeted therapies, and sort of talk together about what does good look like, what you're already doing, how the dialogue between the cardiologist and the oncologist can improve the care of the patient, which, we joke about having you on speed dial, but, these are patients that you really want to be treating. You don't want to be delaying treatment, faffing around, waiting for cardiology advice. So you want to have a system where you work closely together, that the cardiologist has perhaps, slots every week in their clinics so that they could see patients quickly, they can offer advice, because you really don't want to be waiting around and delaying the cancer treatment. And then, then it will build up very quickly once oncologists know that there's an interested cardiologist. There will be a steady stream of oncologists beating their way down the corridors to the cardiologist. So yeah, I think start in a cancer type and provide that rapid access and speedy replies. Email, telephone calls, whatever.
I think from, if I was advising a hematologist, I guess, well, first of all, make sure everyone's motivated, make sure people are aware that there are recommendations for how we should monitor and risk assess patients. I would say don't try and reinvent the wheel. Learn from your neighbors or people who are already doing this, and maybe go and visit a center that has a functioning cardio-oncology MDT, and then work out what bits you could reasonably achieve locally, even if you can't achieve the whole thing, about whether you set up a kind of a tertiary pathway for very difficult patients that you can't manage locally. But it's absolutely the case that not every hospital in the UK will have on-site cardiologists or hematologists, and so developing a network approach, again, you pool resource, you pool expertise in that way. So I think there are means and ways of doing it even within a resource limited setting, but it's about learning from what people are already doing, is what I would advise.
Thanks, Andrew and Rebecca. Very, very interesting and sage advice, I'm sure, for our oncology colleagues listening. So I think it's been a very nice overview over the last 20, 30 minutes about the different challenges of cardio-oncology and the guidelines and the roles of MDTs and the explosion in the different types of cancer treatments, and how that's very challenging, not just for the oncology trainees, but of course for cardiologists, the poor wee souls trying to deal with all of these cardiotoxicities. But very nice to get the thoughts from the oncology and hematology colleagues. Steve.
Yeah, thank you both so much for joining us today. And Arjun, always good to have you with us, and Dan as well. And, obviously you all have a very rich resource environment, having access to one another and just the large institution that you're a part of. But the principles that you've discussed today about collaboration and communication and basic approaches, those are all things that really apply globally to the discipline. So I think everyone who listens to this program will really benefit from the advice that you've given. So thank you for your time today. We really appreciate you joining us and sharing your experience with us.
Thank you.
Pleasure. Thank you.
For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.